I am very pleased and very privileged to introduce our next speaker. Dr. Linehan is the chairman of surgery at the University of Rochester Medical Center and director of clinical operations and co-director of Wilmot Cancer Institute. His clinical expertise is in the multimodality treatment of hepatobiliary and pancreatic malignancies. Dr. Linehan has been continuously funded for his research, studying ways to attack the biology of pancreatic tumors in order to improve patient survival. Please welcome Dr. David Linehan.
Thanks for the invitation. I'm really delighted to be here to speak. I've recently just moved to Rochester. In October was when I arrived, and prior to that I had been in St. Louis at Washington University, where I'd been for the past 15 years really building a program in pancreatic cancer research. So it's just very heartwarming to come to a community like this and to have a grassroots group like this that's really behind us and trying to help us as we try to develop novel therapies and better therapies for this disease that's so devastating. So it's really terrific to come here and see a crowd like this for an event like this, and it's something that I really appreciate. So I'm a surgeon, as she just mentioned, and I'll have to humbly admit to you that surgery is probably not the answer to making advances in pancreatic cancer. It's true that anybody that's a long-term survivor of pancreas cancer has had surgery, but the problem is that most patients actually that are diagnosed with the disease aren't even candidates for surgery, because by the time it's diagnosed, the disease has spread too far and surgery is not a viable option. So this is just a CT scan of a typical patient that walks into my office, and if it's a pancreatic cancer patient coming to see me, it's one of the lucky ones, right? Because 75% of people at the time of diagnosis aren't candidates for surgery, so it's only the 25% that have what we call localized disease, meaning it hasn't spread yet and they show up in the surgeon's office. And so this is a typical patient that would come to see me because they have a tumor. You can see this is the pancreas here, and in this you get the sense here, I don't know how well you can see it, but there's this kind of dark area right in the tail of the pancreas, and that's a cancer. And when you look at the rest of the scan, there's no evidence of spread anywhere, and so this is localized, and this can be removed with an operation called a distal pancreatectomy, where you can go in and you can cut the pancreas here, remove. You typically have to remove the spleen with it as well, and all the surrounding lymph nodes in this area, but that's an operation that can be done. It can even be done laparoscopically with small incisions. So this is a patient that would be a candidate for surgery. And so we'd go to the operating room, they'd have surgery, you'd get a pathology report, usually back in a week. It'll tell me whether the lymph nodes are involved, and then typically after that, I would send the patient on to ARM, where the patient would receive chemotherapy as sort of an insurance policy to prevent this cancer from coming back after a successful operation. Now, this is the survival curve of about 1,000 patients. This comes from Memorial Sloan Kettering, and many of these patients I actually operated on because that's where I trained when I was doing my training in pancreatic surgery. And this is 1,000 patients, and this is the results after surgery. So this is the 25% that were had the highest likelihood of survival because they had surgery. They still had localized disease. And you can see when you get out to 5 years, a very small percentage of these patients, about 6% of these patients, are still alive. So even after a perfect operation, the patient did well, didn't have any complications, went on to get their chemotherapy, this is what the survival curve looks like. Only 6% are alive at 5 years. Are there any 5-year survivors of pancreatic adenocarcinoma here in the room? 1, 2. So this gives you an idea about the odds of that and how lucky you are. So I do want to shake your hand because maybe some of your luck will rub off on me if we do. And one of the things that when we had an event like this in St. Louis, we really, we acknowledge the difficulties we have in this disease, but we want to make it a celebration of survivors because it's such a rare event for somebody to survive this. And as a result of that, there's a lot of what I call nihilism about this disease. And those of you that have been affected by this disease probably know a lot about it. You talk to somebody and you say you have pancreatic cancer, and they'll say, well, my uncle had that and he lived for 3 weeks, or nobody ever survives that, or you should settle your affairs. And so And that's not even in the general population. That's physicians that will say things like that to patients. And I think, you know, you gave a good example of that, where you kind of shrug your shoulders and greet patients with this hopelessness, which I think is exactly the wrong approach in this disease. And so I want to show you this, because I think this is important. This is a relatively old paper that was published by Mark Talamonte, who's actually a pancreatic surgeon. He's going to be here in a few months as a visiting professor in my department of surgery. But he looked, and this is using a big national database of patients that are diagnosed with pancreatic cancer, and there's about 10,000 patients. And these are patients with clinical stage 1 disease. So what I showed you, small tumor, localized, hasn't spread yet. And if you look at what happened to these patients, only about 30% of them had surgery, and 71% of them did not have surgery. And so then the question is why didn't they have surgery? And if you look, this is about 40%, and they were never offered surgery. So there's some reasons not to have surgery. Sometimes the patient's too elderly and frail and wouldn't tolerate an operation. Sometimes the patient refuses surgery. Sometimes they're too old for an aggressive surgical approach, or they have too many other medical problems. But these people could have been candidates for surgery, and they weren't. And so the question is why is that? Why is there so much nihilism? Why is there so much hopelessness? Why aren't these patients having surgery? And it's my belief that every patient with this disease should be enrolled in a clinical trial, because we're not going to make progress in this disease unless we study novel therapies. And boy, isn't this a missed opportunity for that. If you look at the ones who are at the best of this are the pediatricians, the pediatric oncologists. So I think it's 100% of kids with cancer are enrolled in a clinical trial, because the pediatricians got together and they said, cancer in children is unacceptable. We're going to beat it. We're going to design trials. We're going to have novel therapies. And every single child in this country with cancer, for the most part, is involved in some kind of clinical investigation. And it should be the same thing with pancreas cancer, because we're not going to make progress unless we're doing that. And that behooves us to design clinical trials, to offer clinical trials, so that when you come to our institution, we say we're not happy with the standard therapies the way we are, and we want to test new therapies, and we want you to participate. It requires a lot of bravery on the patient's part, right? Because we're trying new things, and we don't know that they're better. If we knew that they were better, they would be standard therapy, and so we have to test them in patients. And so it requires a lot of bravery on the part of the patient. But I've got to tell you, I've been taking care of pancreatic cancer patients for the last 20 years, and patients with this disease get it. They want to participate in trials. They understand what they're up against. They want better treatments in case that someone in their family develops it. They worry about their next generation and whether it's heritable. They want better treatments for themselves. So they're incredibly benevolent, they're brave, and they participate in trials, so it's our job to offer trials. So this is what happens when you don't offer these patients surgery. The ones that get surgery with this stage 1 disease are much more likely to survive. And if the ones that aren't offered surgery, they do just the same as patients with metastatic disease. So we got to combat this nihilism. We got to enroll patients in trials. We got to make sure that patients that are candidates for treatment are getting it. And this is a picture I show every time I give a talk about pancreas cancer, because in St. Louis we started an event very similar to this, and like I said, we tried to make it a celebration of survival. And when we started it, I think 12 or 14 years ago, there was probably only 18 people that showed up, and each year it got bigger and bigger. And this is the survivors. So this is our group of long-term survivors of pancreas cancer that get together. And every time I give a lecture to any group of physicians, I show this picture, because there's no better way to dispel nihilism than to show this picture of long-term survivors of this disease. And so these are brave patients that did participate in our clinical trials. The best patient is, my favorite story to tell is this lady over here, and I have her permission to do this. We don't have to worry about HIPAA. She told me that I can tell anybody I want about her story, but it's a remarkable story because I operated on her for pancreatic cancer. I guess it was probably about 13 years ago, and she had a Whipple operation, and then we followed her sequentially, and she developed a second pancreatic cancer in the remnant part of her pancreas 8 years later, and she had that resected, and she's still alive and well. So she survived this disease twice. So, so Aram showed this, I think, the same picture, which is a really interesting and unique thing about pancreas cancer. When you look at pancreas cancer under the microscope, often 80% of the cells in the tumor aren't cancer cells. So these are the cancer cells here. You can see that they're bright pink. And then he said there's all these other cells here called stromal cells. And this is one of the reasons why biopsies aren't always that reliable. If you can imagine, if you're sticking a needle in and you put the needle here and take that biopsy, you're not going to get any cancer cells. You'll just get inflammatory cells. So we don't often take comfort in a negative biopsy because the way that this tumor is, you can miss tumor cells. But we asked ourselves a simple question, and we've been working on this problem for the last 15 years, is what are these other cells in the tumor, and could they potentially be an explanation for why this is such a difficult disease to beat? And as it turns out, they are helping the tumor grow. These are immune cells that basically form a shield around the cancer. And if you had the most effective vaccine or you could elicit an immune response to your pancreas cancer, it's never going to work in this environment because the cells that are in there are really suppressing an immune response. And so think of it almost like a wound. I'm a surgeon, so I think a lot about wound healing because wound healing is important. And if you have a wound, what happens is you have to recruit cells to the wound to help it to heal, and those are typically immune cells because you want to prevent an infection. They're coagulation cells because you want to stop the bleeding. And so pancreas cancer is almost like a wound. It's recruiting these cells. They come from the bone marrow, and it recruits these cells to the pancreas cancer, and when they get there, they can really have the opposite effect where they can help the tumor spread and grow. So we've been focusing on these cells, kind of a novel way of thinking about treating cancer. Instead of attacking the cancer cell itself, which we do with the standard chemotherapies, is looking at these cells that infiltrate the cancer and see if attacking those can help. And so we've got some promising preliminary results on this approach. In fact, Dr. Hiesel and I were just last weekend in San Francisco at the big GI cancer meeting where we presented the results where we attack some of these cells. We see much better response rates, shrinkage of tumor than we see with chemotherapy alone. And in some of the patients treated with this therapy in the recent trial that we finished, patients that were not candidates for surgery had such profound shrinkage of the tumor that they became candidates for surgery, and that's obviously something that we really want to see. That's something I'm very excited about, because if we can convert people that can't have surgery to ones that can, then we're going to make progress. So it's just an example of some of the research that's going on here in Rochester, and I think one of the things that you saw, and what I really liked is the way that Huckey and Aram got up and presented their data, because that's exactly what we need. Is we need teams of clinicians and scientists that are teamed up focusing on this problem, because the clinician understands what the clinical need is. They're treating the patients, they understand how, why patients fail, the patterns of failure, and the scientist really understands the cellular mechanisms at the cellular level. And so when you can team those groups up together, that's when progress is going to happen. And if you look at what's happening with funding, that's actually a requirement now of some of the bigger awards that are coming from the NIH, is that it's teams of clinicians and scientists that are really focusing. And so our jobs as clinicians that are treating this disease is to attract the best and the brightest scientists to focus on the problems that we see in pancreas cancer, just like the scientist's role is really to, what Huckey said is to sort of look at the data and tell us what the good ideas are and what the bad ideas are in terms of proceeding to translation, which means developing trials that we can try on patients. And so I think Vivek may have showed this or talked about funding for pancreatic cancer. And you can see this is where we stood in 2003. This is the NIH budget was about $4.6 billion, and only $42 million, or less than 1% of the cancer research budget in this country was going to pancreas cancer, which is the 4th most common cause of cancer death, soon to be the 2nd most common cancer death. So this is a problem. And you can see that the news was pretty good. We started to see incremental increase. And I was around when this was happening, and the reason this happened is because groups like yours actually said, we're not going to tolerate this. It was PanCan, which is a national patient advocacy group, the Lustgarten Foundation, which is one based in New York City, went to the NIH and said, this isn't right, this isn't fair, this is a disease that's devastating, it's a common enough disease where it's the 4th most common cause of cancer death, and we've got to have better treatment for it. So you can see that the news was pretty good. From 2003 to 2007, they funded some very large grants, multi-million-dollar team grants to look at pancreas cancer. And so there was some optimism. This is the more current slide where you can see, so the numbers look better. We went from 40 million to 100 million, so really kind of doubling the funding since 2003. But I'm concerned about this. You know, we don't want to see that trend go this way. It's still it's still around 2% of the NCI budget's being spent on pancreas cancer. I don't think that's enough based on the disease, what this disease does to people. And so that's my job, that's your job, that's everybody's job to kind of demand that there's more resources focused on this really difficult to treat malignancy. So that's all I have to say, because I think the question and answer form is really kind of the most important part of this meeting. So I want to make this more of a dialogue than a monologue. So I think probably at this point it's best to invite the whole panel up and then open up for discussion and for questions. But again, I just want to say thank you very much for inviting me. I'm so excited to see this level of enthusiasm and involvement in the community, because this grassroots community efforts are so important to what we're trying to do. And like Hucky and Aram said, it was a small seed grant that came from funds from you that resulted in a $2 million grant from the federal government to look at this. So the grassroots efforts matter so much to us, and we just really appreciate that you're working with us. And then we want you to hold our feet to the fire. We've got to be offering innovative treatments. We've got to be fast-tracking promising science to get it to the clinic so that we can test novel therapies. And we've got to offer clinical trials to every patient that wants to participate. So thanks very much. I really appreciate the opportunity to talk to you.